When a patient presents with a pathological clot, the common reflex is to reach for a blood thinner. Clinically, this is a dangerous misnomer. Pharmacological agents do not decrease the physical viscosity of whole blood. The idea of thinning the fluid is a physiological fiction that obscures how these drugs actually function. To safely treat coagulation, we must discard that vocabulary for the correct clinical umbrella term, antithrombotic drugs. Managing a clot requires moving past generalized lay terminology. Safety depends on a precise taxonomy where every drug is categorized by its biological target. This taxonomy is structured to map perfectly to the body's natural two-step process of hemostasis. Primary hemostasis begins when a vessel breaches. Platelets rapidly aggregate at the injury site, forming an unstable plug. Secondary hemostasis follows via an enzymatic cascade, weaving a permanent fibrin mesh over the platelets, locking them into a stable clot. The pharmacological arsenal is divided into two branches that correspond to these two phases. The green antiplatelets on the left target the cellular phase, while the blue anticoagulants on the right target the enzymatic phase. The choice of drug depends entirely on whether the underlying pathology is driven by the cellular clumping of platelets or the enzymatic formation of fibrin. We'll begin with the green branch of the chart. The primary mechanism of all antiplatelets is the prevention of platelet aggregation. Column 1 identifies class 1, aspirin, which functions as a specific COX-1 inhibitor. Historically, aspirin was used as a primitive antithrombotic for decades before researchers fully mapped its specific molecular pathway. By irreversibly inhibiting the COX-1 enzyme, aspirin causes a downstream drop in thromboxane A2. Without this signal, the platelet cannot activate or recruit other cells to the site. Because platelets cannot regenerate enzymes, this intervention permanently alters their internal signaling, stopping cellular activation at its earliest possible stage. Moving to column 2, we find class 2, P2Y12 receptor inhibitors. These agents work by blocking the ADP receptor on the platelet surface. This class includes both irreversible inhibitors, like clopidogrel, and reversible agents, like ticagrelor. Column 3 highlights class 3, the GPIB/IA inhibitors. These target the final common pathway of platelet activation. By blocking this specific receptor, these drugs prevent fibrinogen from cross-linking adjacent platelets, making aggregation physically impossible. Finally, column 4 details PDE inhibitors. These operate through an intracellular mechanism, increasing CAMP levels to keep the platelet in an inert state. Whether the target is COX-1, ADP, or the GPIB/IA receptor, every agent on the green branch is designed to keep platelets isolated and deactivated. Shifting to the blue side of the taxonomy, we move to the anticoagulants. These drugs are designed to interfere with the enzymatic factors of the coagulation cascade. Column 1 introduces class 1, vitamin K antagonists, with warfarin serving as the primary example. Warfarin's mechanism is systemic. It inhibits the enzyme vitamin K epoxide reductase within the liver. This inhibition prevents the synthesis of several clotting factors, specifically I, VI, IX, and 10, effectively breaking the sequence of the coagulation cascade. Warfarin acts as a broad-spectrum disruptor, starving the coagulation cascade of the essential enzymatic building blocks required to build a fibrin mesh. Column 2 covers the heparin group. These agents rely on activating the body's natural antithrombin to neutralize clotting factors. Unfractionated heparin provides broad inhibition of both thrombin and factor XA. In contrast, low molecular weight heparin is engineered for more specific targeting of factor XA. Column 3 shows the direct oral anticoagulants, or DOACs. Unlike heparins, these do not require antithrombin to function. These drugs bind directly to their targets. The ixabins, such as apixaban, target factor XA, while dabigatran is a direct inhibitor of thrombin. This direct approach also characterizes class 4, the non-oral direct thrombin inhibitors like bivaluridin. The evolution of this blue branch shows a clear trajectory in pharmacology, moving from systemic factor depletion to surgical molecular inhibition. With the entire taxonomy mapped, we can now synthesize these green and blue branches into a clinical framework. The bottom two summary boxes detail the overall clinical action for each branch, aligning the drug's mechanism with its intended physiological environment. High shear arterial environments require antiplatelets. Because fast-moving blood washes away coagulation factors, these clots are driven by cellular aggregation, creating platelet-rich clots. In contrast, the low shear environment of the venous system allows local coagulation factors to accumulate. This creates fibrin-rich clots that are best addressed by the blue branch. Success in treatment requires the molecular mechanism of the drug to map precisely to the anatomical flow dynamics of the clot's location. This distinction is why the treatment for a myocardial infarction is fundamentally different from the treatment for a deep vein thrombosis. A myocardial infarction involves an arterial rupture where platelet aggregation is the primary driver, mandating the use of antiplatelets like aspirin or clopidogrel. A deep vein thrombosis occurs in a venous environment where fibrin production dominates, requiring anticoagulants like apixaban or heparin. Reverting to a generic blood thinner mentality in these scenarios risks selecting an agent that is molecularly ill-suited for the specific pathophysiology. Clinical mastery requires moving beyond a drug's basic function to understand exactly where and why its molecular target becomes relevant within the human vascular system.